But I think it's quite special that we've been able to have quite a significant amount of investment and commitment to exploring these different models of survivorship care in Victoria, and that it's great to see that we have an ongoing commitment to continue to work to improve the care of cancer survivors. We should acknowledge too that also within VCAP was a commitment around long-term follow-up of paediatric survivors, which we haven't talked about today, but is also funded by the Department of Health. So as we've heard, seen there are a number of diverse models that have covered different age groups, different cancer types, different geographic areas, and that we've seen an exploration of a number of different types of post-treatment care and different models of care. We've heard about shared care with general practice, with nurse-led clinics, self-management, long-term follow-up clinics, and the importance of partnering with other organisations, whether they're NGOs such as Cancer Council Victoria and with the Cancer Helpline, but also partnering with community-based services. And Sharon's projects partner with community-based gyms. So we're absolutely going to, this can't all happen in a cancer centre, and we have to think about other ways of forming partnerships and providing better care. So at the beginning I talked about some of the principles about survivorship care, and we talked about needs assessment. We've heard a lot about that this afternoon. We've talked about risk stratification and some of the challenges around that, but we're going to have to try and grapple with those and make some progress. We've heard a lot about the importance of provision of information and support for survivors, partly through survivorship care plans, partly through a patient-held record, at least in one of the projects, and as I said, about partnership with other organisations. There's also, and I guess that this is part of the functions of today, the need for further education for a wide variety of health professionals. I've also just jotted down that we've identified that there are a number of challenges, and it seems so obvious, but certainly at Peter Mac, and we were having this conversation yesterday, we don't have a routine process to identify when people are due to finish and when they actually do finish, which seems kind of important if we recognise that this is an important point in the journey. It's not the only point in the journey, but it would be worth knowing when people finish treatment. Some of the barriers and some of the projects have been referral into survivorship programs, and that's seen, I guess, in a lot of the literature as well. We've heard about we need to have good tools in the community of practice meetings, and hinted on today, there are some issues about having appropriate tools for assessing need and what need we're wanting to identify and respond to. I've jotted down, and I feel like I've said it 3 times in the last couple of minutes, appropriate models around risk stratification. It's going to be a big piece of work, but we do need to get there, and I've shook my head when I was in a meeting with John recently saying this has really got to be our priority. I'm going, oh God, but it is. We've heard a lot today about effectively working with general practice, and I think that over the last couple of years, all of the projects have tried to look over the wall and see what primary care looks like, and tried to understand, and I know it's embarrassing to admit that I'm one of those people, to try and better understand how primary care works and how we can work more effectively with primary care, but we can't really tackle this without understanding that better. I think further challenges are around the financial case and sustainability of these projects and further survivorship work, which I guess leads me on to, it's great that all of these projects have positive outcomes. I think we still need to establish the impact of these projects on disease outcomes, as well as on well-being in a robust manner. And the projects were limited. They're not $2 million projects each. They're not a randomised controlled trial. We don't have a formal control group, and in some ways you get what you pay for, and we can't provide as much evidence as we might like, but we may need to think more about building the evidence, as well as establishing, we hope, the cost effectiveness of these models of care. So I'm just going to show you a couple of slides that, here's some I prepared earlier. Now, there should be an easy way to do this. Oh, that'll do. Okay, so these are some slides that I'd provided that I must say that we're largely for another talk, but we're about what can we do right now. And this is the one I'm going to start with because it's most relevant to today. So we know that there's lots of work around survivorship in the state, and it's really important that we continue to meet to share that experience. And we'll be talking with the department about how can the ACSC facilitate that discussion. Because I've learned an enormous amount from the experience of the VCSP projects, and we need to continue to share that. I think that there's learnings from ACSC. We are trying to sort of build some principles and to build some toolkits around survivorship care. As a little bit of a plug, COSA and the World Cancer Congress are both meeting in Melbourne in the beginning of December, and both of them have a part of their theme is around survivorship. So note the dates, December 2 to 6 to be part of both meetings. And there'll be a lot more about survivorship there. As I mentioned before, Mary McCabe, who's led the survivorship program at Memorial in New York for quite a long time, she'll be out for the meetings as well. And a variety of other speakers, so great opportunity. This is, I guess, what am I going to do tomorrow in my practice that will be different around survivorship care. We've heard a little bit about this particularly in the, I think, probably best illustrated in the Royal Melbourne Women's Breast Cancer Project. They think about the end of treatment at the very beginning. So at the initial MDT, creating an expectation about how people will be managed at the end of treatment. So preparing people for follow-up, I think, is really important. And it also helps prevent problems. So if we think about fertility preservation, you need to think about that early. So again, if we're thinking about survivorship issues early, that will help. Certainly we talked about one of the projects about people coming in to see a surgeon one day and perhaps in a non-coordinated way seeing somebody else at the treatment team a couple of days later. And I think that seems like a really easy, low-hanging fruit in terms of how can we make better use of our resources and provide better care for survivors. So think critically about, is follow-up evidence-based? Can we streamline things? Does it need to be hospital-led? And there are certainly plenty of examples where we think, well, women with early-stage breast cancer, there seems to be good evidence from randomised control trials, at least some women would fit in that group. That it would be safe to be non-hospital based, so led by GP or by nurse-led. This is about auditing current practice. So do we have excessive outpatient review appointments? I know that we do at Peter Mac. I'm going to get told off now. Didn't say that. We certainly have the opportunity to enhance communication with primary care, and we need to think about that. So consider groups of people who can be safely transitioned to care in the community. We need to consider funding opportunities, and activity-based funding may well, within the same funding envelope, give us the opportunity to provide better care, which might be substituting medically led care by nursing or allied health led, or telephone-based review or group-based sessions, which might also support better care, simultaneously thinking about transferring people to the community. We need to think about incorporating needs assessment and supportive care screening in the post-treatment phase, which again has been largely emphasised on the initial treatment. It's an easy thing to provide better information for survivors. The Cancer Council has very good information. We've got the DVD as well, and people say they don't get it and they appreciate it, so that seems pretty easy. Providing health promotional advice is relatively straightforward, and most of us have some ideas about this, so we can emphasise that. Involving community agencies, particularly, as we heard about, Cancer Council has a range of support programs, information and support, but so do other organisations, and linking people to other survivors. We heard about the Cancer Connect program. So I think that's probably my last slide. So I just want to, don't know why I'm getting rid of that. I'm getting rid of my slides, not the microphone. I just again to thank everybody for coming along today, to thank the Department of Health for funding all of the projects, and also for funding, part funding, the Australian Cancer Survivorship Centre as well. Thank the Cancer Council for providing us with this great space for today. I think that we do have a lot of momentum around survivorship, so we will continue to be engaged with you as we shape VCSP2. To say that the reports are due any second, So you will be seeing the reports. They will be publicly available. The other thing to say is that there is some work being undertaken to summarise the work of the 6 pilots and to learn what are the general themes, the general learning. So that will be reported separately, and we'll also be aiming to publish that and distribute that more widely. So finally, to say, if you please remain engaged with both the Survivorship Centre and also with the Cancer Council. If you'd like to be part of the clinical network, then I believe the forms are outside, and otherwise chat with Danielle, and thank you all again.